All righty. Well, welcome to our urinary and reproductive system session for this week. So let's just jump straight on in and start with number one. We have left ureteral stent placement and extracorporeal shockwave therapy or lithotripsy, also known as ESWL, of the left kidney are performed. So what code or codes should we use? So in this one, we have two that have 50590 and then two that have 52332. Would look at the 50590 first, just because the 52332 is going to be a secondary procedure on this one. So let's look at the 50590. And that is for lithotripsy, extracorporeal shockwave, or your ESWL. So we know that we need, oh, I have no idea what just happened there. We know that we need that ESWL 50590. And we just need to determine, do we need the 52332 as well? Let's go to 52332. And your 52332 is a cystourethropy with the insertion of an indwelling ureteral stent, also known as a Gibbons or a double J type stent. So what do you guys think? Should we also code 52332 in addition to the 50590? Okay, so I have some saying yes, some saying no. So our 50590 is only for the ESWL or the extracorporeal shockwave lithotripsy. Now, the stent placement that we did, that is going to be coded separately because that's a separate procedure. Not everybody that has an ESWL is going to have a stent placement, so it's not going to be considered an integral component of that procedure. So we are going to code the 52332 for that stent placement as well. Make sense? Any questions? So 52332 for the stent placement, 50590 for the ESWL. Any questions on that one?
No.
Okay. Number two, patient presents today for treatment of benign prostatic hypertrophy or BPH and urinary retention by transurethral microwave thermotherapy or a TUMT. So this one we're going to code CPT and ICD-10. So we have two that have 52648 and two that have 53850. So let's do the 53850 just because that comes first numerically. No, 52648 would come numerically, but I'm already there. So 53850 is for a transurethral destruction of prostate tissue by microwave thermotherapy. Does that sound like what we did, or do we want to go look at the 52648 just in case? 52648 is for a laser vaporization of the prostate, including control of post-op bleeding, complete. So which one do you think? Should it be the 53850 or the 52640?
The 52640.
Or sorry, 48. So, okay. So we're going to keep the 52648 or we're going to eliminate it?
Keep it.
Okay. So I had one say keep, one say eliminate. 52648 is for a laser vaporization. Okay. And then for 53850 is going to be the transurethral destruction by microwave therapy. So we're going to keep 53850 because that is going to be the TUMT. Everybody see that? So again, the 52648, that is for a laser vaporization, and there's really no mention of your microwave thermotherapy. Your 52648 is also another term that they can use as a green light ablation. And again, there's not really any laser therapy that's being done. We're using that microwave thermotherapy. Okay. So now we need to determine our ICD-10. So we need to narrow down between N40.0 and N40.0 and N40.1. Let's go look at those. N40.0 is BPH without lower urinary tract symptoms, and N40.1 is BPH with lower urinary tract symptoms. So do we think it's 0.0 or 0.1?
I want to say it's point one.
Okay. What's making you think 0.1 with our lower urinary tract symptoms?
Well, the benign prostatic hyplasia with lower urinary tract is urinary retention.
Yep. Our urinary retention. Yep. Perfect. Yep. So our urinary retention is going to be our lower urinary tract symptom. Okay. Make sense? Any questions? Okay. Number 3, a partial cystectomy is performed due to the prior administration of radiation. It is complicated due to the extensive adhesions, and it does require an additional 2 hours beyond the usual cystectomy procedure. So we have 2 that are the same code. One of them has a 22, one of them does not. So let's go take a look at the 51550 and 55 since they're right there together. So 51550 is cystectomy, partial, simple, and then the 555 is a complicated. And it's done for post-radiation, previous surgery, or difficult location. So which code should we use? The 50 or the 55? Yep. So it should be the 55. So we're going to rule out A and D. Okay. Now we need to determine, are we going to use the modifier 22 for an increased procedural service? Okay. Look at your code description. Your code description is for a complicated procedure, and it is for post-radiation, previous surgery, or difficult location. So it is due to the prior administration of radiation. So there's our post-radiation portion. And then it's complicated due to the extensive adhesions because of that prior radiation. So we're not going to use our 22 for increased procedural services for the additional 2 hours because it's already included in that complicated portion of the procedure. So if you were to submit a modifier 22 and then submit your operative report with your claim, and then it was reviewed for additional payment, then there would be no additional payment that would end up being given for it. Because again, the additional 2 hours is already included in the complicated portion of the procedure. Does that part make sense? So don't always assume that just because they do 2 additional hours, we're always going to add a 22. So the complicated 51555 is going to include that additional payment. Okay. Any questions on that one? I know that one's tricky. Okay. Number 4, a 63-year-old gentleman comes to the emergency department complaining of the urge to urinate, but has been unable to empty his bladder. The provider decides to place a Foley catheter to relieve the urine retention due to prostate hypertrophy. So what is going to be our procedure and diagnosis code? So let's go look at 51701 and 51702 because they're right there next to each other. 51701 is an insertion of a non-indwelling bladder catheter, such as a straight catheterization for residual urine. And then 51702 is going to be an insertion of a temporary indwelling catheter, simple, such as a Foley. Okay, yep, we're going to use 51702. So let's get rid of A and D. Okay, so now we need to know, we know N40.1 is our code because it's in both. We just need to know which one should we sequence first. Should we sequence the N40.1 first, or should we sequence the other code first? So our R33.8 is going to be the urinary retention. And then R33.9 is
And 40
retention of,
should be
I'm
first.
sorry, go ahead.
No, and 40.1 should be first or not?
That's what I'm asking. Should it be first?
Yes, I think.
Yes. Why
Yes.
should what's your reasoning? Not saying it's wrong, but what's your reasoning for N40.1 being first?
Now, is it part of that guideline? I don't know. I'm thinking it's because it's.
Well, what's the reason? So the reason
The
for
symptoms. Yeah, the symptoms.
the reason for the encounter is unable to empty the bladder, but it's due to the prostate hypertrophy. So that's what's bringing them in, right?
Okay.
And then it is the urinary retention.
That they're doing. That they're doing. Yep. That's the procedure, I should say.
Yep.
Right?
Yep.
Okay.
Well, no, the procedure is not the urinary retention. The urinary retention is why they're doing the procedure.
Okay, gotcha. Okay, I got you.
Yep. Okay.
And the R33.8 has a code first.
Yep, exactly. That's what I was getting ready to say. If you go to R33.8, then there is a code first, if applicable, any causal condition such as an enlarged prostate, which is your N40.1.
Okay.
Yep. Yep. So there's a couple different ways that you can reason why N40.1 should be first. Yep. Okay.
Tiffany,
yes.
I have a question.
Okay.
The R33, what threw me off on that one, outside of, I know that R needed to come last, but I was going with 33.9 because, because that was unspecified. Okay. But the other one that was throwing me off because it said other.
Well, yes, because the other retention of urine is going to be due to the BPH.
Okay.
Due to the hypertrophy. That's what the other component of the urinary retention is. Correct.
Okay. Thank you.
I know. There's some very odd wording in these that's very tricky.
Amen to that.
Yep. Okay. Any other questions?
No, thanks.
You're welcome. All righty. Go ahead and go on to number 5. So, patient is a 68-year-old male admitted for a left flank nephrectomy with partial ureterectomy. He has left renal atrophy and chronic renal inflammation. The pathology report reveals marked glomerulosclerosis, chronic inflammation of the kidney, renal pelvis, and the ureter. So we're going to do ICD-10 and CPT. So let's do our CPT. We have 50220 and 50230. So those are pretty close. So let's go look at those. So 50220 is a nephrectomy, including a partial ureterectomy, any open approach, including rib resection. And then 50230 is a radical with regional lymphadenectomy and or vena cava thrombectomies. So we had a left flank nephrectomy with a partial ureterectomy. So did we do it just that procedure, or did we do it radically with a regional lymphadenectomy as well? Yep.
It's the procedure.
Yep, just the procedure. We didn't do any radical portions of it. Okay. So now the $1 million question is, what are our ICD-10 codes? So let's go look at N26.9. N26.9 is renal sclerosis, unspecified. And then N05.1 is unspecified nephritic syndrome with focal and segmental glomerular lesions. So what do you guys think? Should we use N26.9 for renal sclerosis unspecified? Or should we use N05.1 for the unspecified nephritic syndrome with focal and segmental glomerular glomerular lesions? Okay, so I've got one for each in the chat. Okay, I just got 2 more, one for each. So it sounds like we're split down the middle on this one. We're not sure if it should be the N05.1 for the unspecified nephritic syndrome, or should it be N26.9 for renal sclerosis? Okay. So when in doubt, okay, we have glomerulosclerosis. So what's the glomerulo portion of it? With sclerosis, we have that word that matches, right? What's the glomerulo portion from a med term standpoint? Yep, of the kidneys. Yep. So now that we know that glomerulosclerosis is going to be sclerosis of the kidneys, that being said, do you think it should be N26.9 or the N05.1 now? Yep, should be N26.9. Because that N26.9 is going to be for the glomerulosclerosis. The N05.1 we don't have an unspecified nephritic syndrome. We do have glomerular lesions because of the glomerulosclerosis, but that glomerulosclerosis is more specified, more specific than an unspecified nephritic syndrome. That makes sense? Any questions on that? I know this one's a little tricky because they're not giving us the exact words that we need. Okay. All right. Number 6, Mrs. Jones, who is G1P0, is diagnosed with polyhydramnios and is scheduled for an amniocentesis to aspirate some of the excessive fluid from her amniotic sac. The amniocentesis is performed under ultrasound guidance. So what is / are the code or codes for the procedure that's performed? So we have 2 with 59001. We'll look at that one first. So 59001 is going to be an amniocentesis therapeutic amniotic fluid reduction, and it includes an ultrasound guidance. So 59001 is our code, right? Are we supposed to report the ultrasound guidance separately? No, correct. So we are only going to code the 59001 because that code is the amniocentesis itself, and it includes your ultrasound guidance. So from a testing perspective, don't go, oh, there's ultrasound guidance. We need a 769 code, right? We need a 70,000 code, and just automatically pick that. You always want to go to your code and see if your code includes the radiological component or the radiology component within that code description. Okay. Any questions on that one? Perfect. Number 7, patient has a LEAP conization for CIN2. So what are our CPT and ICD-10 codes? We have 2 that are really close, 57522 and 57520. And then 2 that are really close, 57460 and 61. Or you can go with your ICD-10 and rule out. Which one do you guys want to do? Do you want to do CPT or do you want to do ICD-10 first? I have my CPT open. So let's do CPT. So 57522 can be a conization of the cervix with or without fulguration, with or without DNC, with or without repair, and it's for a loop electrode excision. And then 57520 is cold knife or laser. So let's go look at the 57460 because these are very similar in wordings with the codes. 57460 is for a colposcopy of the cervix, including upper and adjacent vagina, and then with loop electrode biopsy of the cervix. 57461 is the colposcopy of the cervix, including upper and adjacent vagina, with loop electrode conization of the cervix. So it should not be the 60 or the 61 because it's not a colposcopy of the cervix. Yep. So we didn't do colposcopy. And then our 20 or 22, it's not 20 because it's not a cold knife or laser. And then your LEAP, if you don't know what a LEAP is, that is your loop electrode excision procedure. So next to 57522, go ahead and write the word LEAP. So if you have a code or if you have a scenario that indicates that a LEAP is done, that you aren't going to have to guess if that 57522, the loop electrode excision, is the LEAP or not. Okay. Any questions on that one? Number 8, a 23-year-old woman presents with sudden lower left quadrant pain, which does not resolve. The decision is made to perform an exploratory laparoscopy, revealing a cyst on the left ovary. The cyst is then removed along with a partial oophorectomy. So what are going to be our codes? So we have 2 that have 58661, and then 2 that have 49320. Let's look at the 49320 first, because that is going to be in a different section. 49320 is for a laparoscopy, abdomen, peritoneum, or omentum diagnostic with or without collection of specimens by brushing or washing. So if we did a procedure, right? I know we went in originally for an exploratory laparoscopy, but if we then did a procedure, are we going to report that diagnostic laparoscopy first or as well? Correct. So we should only report the surgery or the procedure and not the diagnostic portion. So then let's go to the 58661 and the 58925. So 58661 is a laparoscopy surgical with removal of an adnexal structure, partial or total oophorectomy or a salpingectomy. And then the 58925 is an ovarian cystectomy, unilateral or bi. So should we use B or D? Okay. So we should use B, 58661, because this is a laparoscopic procedure versus 58925, which is an open procedure. Okay. Any questions on that one? Okay. Number 9, a pregnant patient presents to the hospital in active labor. The obstetrician providing her prenatal care is contacted to perform the delivery, and then the provider delivers the twins vaginally. The obstetrician will also provide postnatal care. So we have 59409 is in 2. So let's go look at 59409. Five nine four zero nine is vaginal delivery only, with or without episiotomy and or forceps. So are we only going to report the vaginal delivery times 2? Right. So we know that 59409 is going to be, again, that vaginal delivery only, right? So that's going to be for baby B. Baby A, we have to report a global package as well. So we're going to report global package 59400 for baby A. And then baby B is going to be our vaginal delivery only, which is the 59410. But we can't just report 59410 we have to put our 51 modifier on there because we have to indicate that there's multiple babies, multiple procedures. Okay. Any questions on that one? So twins are a little unique, right? We're only going to report a single global package because we can't report the global package for both because they're going to get, at that point, if we do that, they're going to get a prenatal care twice and then postnatal care twice, which is not correct. Yes, should be 594, sorry, 09.
How do you know when you need a global package? And
Be
would 59400 always only be reported once?
Yes. So 59400 is only going to be reported once because every pregnancy is only going to have one global package. And then we know for this one, it's going to be global because the same obstetrician that did her prenatal care is also doing the delivery and is also doing their postnatal care. Now, if, for instance, this was a different situation and there was a different obstetrician that was doing prenatal and postnatal, but there's another doctor that is doing the delivery only, then for that day, then you would only report the delivery for both. But let's say your doctor's on vacation and they're not, they're not available to do delivery, then their normal OBGYN that does the prenatal and the postnatal are going to report the prenatal and the postnatal separately. And then whoever the doctor is that does the delivery is going to bill for the twins delivery only. So not every single pregnancy is going to have a global package, but if the provider does all of the care, prenatal, delivery, and postnatal, then it would have a global package. Does that make sense?
Yeah. So if the
Okay.
separate doctor did delivery, it'd be just the 5940951 for just that. Or excuse me, 51.
Well, yes. So it would be 59409 and then 59409 with a 51 because we have to have, so let's say Dr. A did prenatal and postnatal, right? And then Dr. B, who is not in the same group practice, then at that point they do the delivery only. Then for prenatal and postnatal, they would end up doing, depending on how many visits, but we're just going to say it's the normal amount. It would be 59426 for their prenatal, and then 59430 for the postnatal or the postpartum care. Okay. And then for the delivery of the twins, it would be 59409 and 59409 with a 51 because 59409 is baby A with a 51 is your multiple for baby B.
Perfect. Thank you.
You're welcome. I know twin deliveries can get a little crazy and messy. Okay. Any other questions on this one? Okay. Last one, number 10. A woman with abdominal pain and bleeding has a diagnosis of multiple fibroid tumors and undergoes laparoscopic resection without hysterectomy. After the abdomen is entered and inspected, it is found that she has 5 separate intramural fibroid tumors. The fibroid tumors are then successfully removed with a total weight of 300 grams. And then your pathology confirms a leiomyoma or myomas or fibroids. So let's look at ICD-10 because we can rule out 2. So let's look at D25.1 and D25.9. So D25.1 is intramural leiomyoma of the uterus. And then D25.9 is a leiomyoma of the uterus unspecified. So should it be 0.1 or 0.9? Yep, 0.1. So then let's go look at 58545 and 58546. So 58545 is laparoscopy, surgical myomectomy excision, 1 to 4 intramural myomas with total weight of 250 grams or less. And then 58546 is 5 or more intramural myomas and or intramural myomas with a total weight greater than 250 grams. So should it be the 4.5 or the 4.6?
My bad. B.
Okay, no, you're good. Yep, it should be the 4.6. Yeah, because we have a total weight of 300 grams, which is greater than 250, and then 5 separate fibroid tumors. So what if this had 3 separate with a total weight of 300? Would that change our answer?
Yes.
Okay. Read your code description very carefully.
Oh, I'm sorry. Did
because
you say
it's
3
4.
separate? Oh, okay.
Yes. So it's one or the other criteria has to be met. If we have 3, but the total weight is greater than 250, we can still use 4.6 because it doesn't have to be both 5 or more and greater than 250. It has to be 5 or more and or greater than 250. So whichever one is going to give you the most, you can code. So even if we had 5 with a total weight of 200 grams, we can still use 4.6 because we've met the 5 or more, right? We don't have to meet both the number and the weight. We just have to meet one or the other. Does that part make sense?
So would the number or the weight be more important?
Whichever one will give you the higher number or
The
the
higher.
higher code.
Okay.
So yeah, so like that's what I was saying. It could be one or the other. It doesn't have to be both components in order to code the 4.5 or the 4.6. Whichever
Okay,
one is going to kind of bump you into the higher one is totally fine.
okay, thanks.
You're welcome. I know. It's a little weird whenever some of your codes have and or, and then you might meet the number for the 4.5, but the weight for 4.6, or vice versa. But yes, whichever one will give you the higher reimbursement or the more detailed code you can use. Okay. We went through those pretty quick tonight.
So you really got to pay attention, Tiffany, to the and or then too.
Yes.
I would say,
Yep.
right?
Yep. If it's and/or, then it means one of the two. If it's and, it has to be both, right? If it's or, it can be one of the two as well. But if it says and/or, then yes, you can use either one of them. Correct.
Got it.
Nancy, what's your question, hon?
Hi, sorry.
No, you're fine.
I have my daughter here with me. I'm sorry if you might hear her in the background, but
That's okay.
I was wondering if we could backtrack to the pregnancy, to the delivery again. Yeah. So if we could just backtrack there, I have a question as far as the global packages. So in a normal case scenario, we would always use a global package, but you said in the case of the provider does the, you know, delivery on a separate day, then we wouldn't use the global package?
No, it's not necessarily delivery on a separate day. It's if Dr. A is on vacation, who normally is going to do your prenatal and your postnatal, and
Okay.
then Dr. B is the physician on call.
Oh, okay.
Now, to throw another kink into it, if Dr. B is part of the same practice as Dr. A, and they're just the doctor that's on call, then you would still bill the global package. But let's say, for instance, Dr. A is just a separate practitioner on her own. She's not part of a practice, right? And then the hospital has Dr. B, who's a totally different practice. Then that's when we would bill them out separately.
Okay, and when we're billing them out separately, I know this isn't going to be like a test question or whatever, but if we were to bill this out separately in a like the real world, how would we do that? Would we have one bill, like would we do one scenario and then another scenario? Like how would that look?
Yeah, so this would be claim A, right? This would
Okay.
be on one claim. And then this would be on a totally separate claim because this is a totally separate doctor, right? So
Okay.
claim A is going to have date range. I'm just going to throw out some random dates, right? 1/1/24 through, let's just say, well, hang on. Let me do it this way. For data service, 1/1/24 through 1/8, or no, sorry, 8/1. That's going to be your prenatal care, right? And then for date of service, let's just say 8/4 or 8, let's say 8/30/24. That's going to be their postnatal care. And then let's say that they gave birth on 8/15/24. This is going to have both on the same date of service because they obviously, well, unless one gives birth at like 11:59 p.m. and then 12:01 a.m., right? But normal circumstances, same day is going to be your delivery for both twins. So you're going to have a date
Okay.
range for the prenatal, a date range for the postnatal. And they don't have to necessarily be on claim A. This can be split up in two separate claims. They can bill this on claim 1, this on claim 2, right? And then this is going to be a whole separate provider with their own claim for the date of the delivery only for the twins. Does that part make sense?
Yeah, it makes sense.
Okay.
And you know what? I think this would be pretty common because some people have labors and that last, 20 hours even sometimes. Do you think this would be common to bill separately?
For the most part, it's like as far as billing separately for like splitting them up like this.
Yeah. Like, okay, let's
I mean,
say the doctor.
even with like a long delivery, or like obviously they're in labor for a while,
Mhm.
then the typically, if you are in a practice that has multiple providers, then those providers will just switch out throughout your entire delivery.
Yeah. Yeah. Okay, so if the okay, sorry, I'm sorry. I'm just trying to
You're
speak.
fine. You're fine.
Okay, so if the doctor, the shifts ended for the first doctor and then second
Mhm.
doctor takes over, this is when we would use this, right?
Well, if it's a doctor within the same practice, no, because if we're going to
Oh,
treat,
okay.
yeah, we're going to treat the doctors within the same practice as the same physician, kind of like with our E&M, right? If you're an
Oh,
established
okay.
patient with one, and within the specialty, you're an established patient with all of the ones within that specialty, within that practice, right? So this goes the kind of the same. So if you go to a practice that has multiple OBGYNs, they're going to be the same specialty, right? So if Dr. A is, on call and you see Dr. B within that practice, then at that point, you're going to be able to bill a global package because they're going to be acting as the same physician because they're established within that practice. But
Okay.
this scenario here is, let's say, like I was saying, Dr. A is just a single practitioner. They have their own office. They don't have anybody else in there with them. They go on vacation, and then Dr. B, who is just of a totally different practice, then they come in and do the delivery only. Then Dr. B is going to bill for the delivery of the twins.
Okay. Yep, that makes sense.
Only if
Sorry.
they're completely separate practices. No, you're fine. I know.
Oh, so this really
Twins are
wouldn't be
weird.
common then. Yeah.
It's
Okay.
really not as common, but and I mean it could be one of the things too. It could be that, because I've had a friend that did this. She went on vacation while she was pregnant, and she ended up giving birth in a totally different city.
Oh, wow.
So that would be when Dr. B, in whatever random city that you were on vacation in, that's when it would be split too.
Okay.
I know. It's crazy. It's weird.
Yeah, it is. Hey, but thanks
Pregnancy's
for the breakdown.
complicated. Twins just add a whole different mess into it. So yeah.
Yeah. And I just want to see if I have this correct. If one is delivered, okay, so if one's delivered vaginally and the other is delivered cesarean,
Yep.
then we would do 594. I don't know. Okay, so we would do 59409 plus the 5910, right? Or
Yes. Yep. 59510. Okay. Yep. So if we have twins, one is vaginal, one is C-section. Is that what you're saying?
yes.
Okay. So we are going to do the vaginal first, right? So this is baby A. And then the C-section is baby B. Okay. So baby B is going to be our global package because the C-section is going to have a higher weight value to it, right? It's going to be a more complicated procedure. So the global C-section package is going to be 59510, right? It's our global C-section package. It's going to include antepartum and postpartum care. And then baby A, who is our vaginal delivery, is going to be 59409 with the 51. Even though baby A came out first, we're not going to automatically put the global package on baby A. We're going to put the global package on the baby that has the higher, more complicated delivery.
Oh, okay. So, yeah, that makes sense. Okay. So complication, the highest, it's the same thing with like the most complicated goes first, right?
Exactly. Yep.
Okay.
Yep. So the more complicated in this scenario is going to be the one that gets the global package. Yep.
Okay, thanks
Okay.
for explaining that. I'm
Yeah,
sorry, I have my
absolutely.
daughter in the
No,
background.
you're
Yeah, I
totally
keep
fine.
getting mixed up. Sorry.
So
you're good.
Tiffany, I have a
Yes.
question with that one. What if both of them were C-sections? We'll just use the 59,510 then?
That's going to be yes. So depending on the payer, because most of your insurance payers are not going to recognize that
Okay.
second delivery, C-section wise, is a
Okay.
quote unquote separate delivery because
Okay.
they're looking at the incisions.
Twins.
When
Okay.
you do twins through both C-sections, you're just making, you're doing
One.
through the skin and then you're doing one through the uterus, right? So
Right.
they're only doing one incision essentially. There's
Okay.
not multiple incisions, so you should
Okay.
only
This-
bill one.
The global.
Some
Right.
insurance payers will allow you to bill for a delivery only for the second baby, but not all of them will. So that's why it's important when you're in the real world. If you're in testing, they're not going to ask you about all of that.
Okay.
But when you get out into the real world, just make sure you know your payer guidelines and what they expect to pay for.
Okay, gotcha.
Okay.
Hey,
Thank you.
Tiffany, where would those payer guidelines be? Do you know what page?
They're not in the book. Those payer guidelines are going to be on like their websites. So Cigna, United Healthcare, Humana, whatever it might be.
Oh, so we really wouldn't need that for the exam, really?
No. For testing purposes, no.
Okay.
Okay.
Right.
No.
So I have
Okay.
a kind of unrelated question. So
Yeah.
do the OB/GYNs not get paid until after, say, like the prenatal care?
Correct. Yeah, because unless the only time that they will split up the claims is, let's say, I get pregnant and I start going to the doctor, and then my insurance changes, whether it be because of open enrollment, whether it be my husband switches jobs, whatever it is, right? So if at that point, if insurances change, then we have to bill some of the antepartum care separately. Then, depending on what insurance is what during what portion of the pregnancy, then at that point they can bill whatever the first insurance was for whatever services up until it terminated. And then the new insurance, they would get paid at the end of all of that.
So you would
At
do
the end.
so would you do like the global package, and then would it be like a decrease?
No. So if they switched insurances halfway through, is that what you're saying?
Yeah.
No. So it would be very similar to this. So let's say insurance A, they did 6 prenatal visits. Okay. Insurance B, they did 5 prenatal visits. And then delivery, we're just going to do a single delivery. I'm not even going to do twins at this point. Delivery. And then we'll do postpartum care. Okay. So your 6 prenatal visits for insurance A would be 59425. Okay. The 5 prenatal visits for insurance B would be 59425 again. Then we would do delivery with, we'll say vaginal delivery, just to keep it as
Simple.
as simple as possible. So you have a vaginal delivery code, including postpartum care. And so then this would be code 59410.
Okay.
Does that make sense? So you wouldn't be able to bill a global package for insurance B because they didn't do, well, no, I guess you could. Hang on. Okay, hang on. Let's make this as, so 2 prenatal visits would be 2 E&M codes. And then your vaginal delivery and postpartum would be 59410. If you did, if you did 5 prenatal visits, yeah, okay. Let me back that up. You did 5 9, you had 5 prenatal visits, you would still bill it out like this because you didn't do all of it, so you can't bill a global package. So you would still have to break it out like that.
Okay, that makes sense.
Sorry,
That
I
just
did
seems
not
like a
mean to
long
just
time for
confuse.
them.
I confused myself on that one for a second. Sorry if I confused you too.
Nope, that makes sense. Thank you. I
Good.
just thought it
You're
was
welcome.
odd that they did all that service before getting paid. It's a long time.
Yeah, I know. It's not fun, but that's just what they do. They have to, because they can't assume that they're going to do everything.
Until it's done.
Yeah,
Right.
until it's done, because we can have a plan, right? But we all know plans usually never happen the way that they're supposed to. So, so yeah, they just have to wait until after everything. Now, if they know, like I said, if they know that like insurance is switching, then yes, they can bill for insurance A. And then we have to wait until we're all the way at the end of prenatal care to be able to say, yes, we're doing all of the postpartum prenatal, or sorry, all of the postpartum care. Then we have to wait until postpartum care is done after those 6 weeks.
Okay, so Tiffany,
Mhm.
what happens if on the insurance B, the insurance switched out and there weren't 5 complete prenatal visits? They were only, say, 2 or 3.
So it's
Could
going to
you,
depend on how many. So right above your code 59425, you have a parenthetical note that says for 1 to 3 antepartum visits, which is your prenatal care.
Oh,
Then
okay.
you're going to use your appropriate E&M code.
Oh, okay.
Yep.
All right.
So,
Thanks.
so whatever code you bill for prenatal is going to depend on how many prenatal visits are had underneath that plan.
Okay. Thank
Hey,
you.
You're welcome.
oh, sorry. Hey, Tiffany, I had a really quick question. On one of my questions in my practice exam, it had a abbreviation TC after the code, and I tried to find that in my book, TC. I couldn't find it. Do you know what that means?
That is going to be your technical component modifier.
Oh. I don't know where that is.
It is your technical component modifier. Is the description of it is, let's see, let me find your page for you.
Thank you.
I don't think it's in your, now that I'm thinking about it, I don't think it's in your CPT manual. But let me double check. Yeah, your TC is not in there. So your 26 is, because that's your professional component, right? Your 20 or your 26 is your professional component. TC is your technical component. So TC is going to be used when the facility, well, I guess when the provider does not own the equipment. And so your TC is going to be like the overhead for doing your X-ray or your CT or your MRI. Your 26 is your professional component for the professional service of that X-ray, whatever, as they interpret the image that comes out.
Okay, I'm just writing this down. So we technically, because one of the answers said TC with a 26, so that's incorrect. We can't use the TC
Right.
and
If
26.
it is a TC and a 26, then you should just bill the code because that's going to be considered your global package of that code.
Okay, thank you.
You're welcome.
Hey, Tiffany.
Yeah.
I took my final exam for AAPC last Friday.
How'd it go?
Good. I got an 86, but I
Good.
want to thank you because I watched all of your videos again Wednesday and Thursday, and then I watched a couple more Friday morning before I took it. And your tip on the burn codes with the level, the degree of the burn being in the code helped me because there were several questions on there regarding that, and I was able to get through those very quickly.
Good.
And then your tip with the questions that have a lot of J codes from your HCPCS books for the medication. There were a couple questions like that on there, and your tip for ruling out that way first helped dramatically. So thank you for those tips. They helped a lot.
You are very welcome. Absolutely. Absolutely. It's just a couple of those things that, and like I said, I've been doing this for so long that hey, every little like 10 seconds here and 20 seconds there really adds up. So yes, absolutely.
I guess my problem is the case questions. Those just take up too much of my time. It's like, 6+ sentences.
So with your case questions, look at your answers first and then pick out the words from the codes and the code descriptions. Look for those words as you're reading them. So don't read your cases first. Don't read those paragraphs of information first. Look at your codes, figure out what words you need to be looking for, and then skim through your question or skim through your scenario or your case. And that will that should help speed up on those cases.
Okay, thank you.
You're welcome. Okay. All right, guys. Let's go ahead and end for tonight. If you have any questions, don't hesitate to reach out in the meantime. But if you have any questions, like I said, I'm here for you. If not, then I will chat with everybody next Wednesday. And we will go over 60,000 questions for nervous and eyes and ears. Okay. Y'all have a good evening, and I will chat with you next week.